If you've done an antifungal course and felt better for a few weeks and then watched every symptom crawl back, you're not doing it wrong. The treatment may have worked exactly as it was intended. The problem is that antifungals don't change the terrain that allowed Candida or other yeasts to take hold in the first place. Candida is a normal resident of your gut and your skin, and it becomes a problem when something shifts in the environment around it and it changes form. And until that shift gets addressed, you're going to keep cycling through the same treatments and the same comeback stories. I'm Dr. Kenny, Root Cause Health Detective. That's what we're getting into today. Most people come into this conversation thinking of Candida as something that is foreign, an invader, that something got in behind your defenses, and that's not quite right. Candida albicans lives in your gut and on your skin right now. In most people, it's been there their entire adult lives. It's part of what researchers called the mycobiome, or the fungal layer of your gut microbiome. It's a community of fungi that, for most people, live without causing any major issues. The research is clear on this too, that roughly 50 to 60% of healthy adults carry Candida in the gastrointestinal tract at any given time. They have no symptoms as well. Most importantly, no bloating, no brain fog, no itching, nothing. So the question really isn't about whether or not Candida is there. The question is what changed in the environment around it that allowed symptoms to manifest. Because Candida has a switch, and when that switch gets flipped, everything can change. Here's the biology that most treatment approaches skip entirely. Candida albicans can exist in two different forms. The first form is the yeast form. It's a single cell, it's round, and it's largely not moving around a lot. This is the commensal, or the good natural version of your microbiome, the one that lives alongside your bacteria without causing any trouble. The second is the hyphal form. This is where it becomes invasive. The hyphal form produces these thread-like filaments that can stick to and penetrate the surface of your gut lining. This is the protective barrier, of course, that represents your main immune interface in the gut and along your digestive tract. When that barrier is compromised, things that shouldn't get through do. And this is the form that's associated with symptoms that affect many other systems in your body aside from just the gut and digestive tract. This is the form that correlates with leaky gut, with systemic inflammation, with skin issues, and it's the kind of pattern that doesn't respond well or predictably to short-term antifungal treatments. So what triggers this switch? This is where we talk about environment and terrain and these signals, specifically signals that come from your microbial community surrounding it. When your bacterial ecosystem in your gut is intact, Candida tends to stay in its harmless yeast form. When that ecosystem is disrupted, your microbiome does not like negative space, and Candida is the perfect species to grow in the place of that relative vacuum created by things like antibiotics, chronic stress chemistry, and similar things that shift your microbiome. So the bigger issue here to really tune into is that terrain, and that distinction is why many antifungal focused treatments fall short. So stay with me here, because this is the part that actually explains the cycle most people get stuck in. Your gut bacteria are not passive bystanders in this story here. Specific bacterial families actively suppress Candida's ability to switch into that hyphal form and colonize. Two of the most important are a bacterial family called Lactospiraceae and a family called Bifidobacterium. These are the bacterial species that specialize in producing butyrate. This is a short-chain fatty acid, which is a special form of fat that is anti-inflammatory, and it feeds your gut cells. Essentially, what short-chain fatty acids do is they keep your gut environment appropriately acidic, and this directly impairs both Candida growth and its ability to shift into the more invasive hyphal form. Research that was published in 2025 on biofilms and microbiomes looked at exactly how Candida colonization unfolds in a model of the human colon. What they found wasn't that Candida expanded when overall bacteria diversity dropped, but rather Candida expanded specifically when those butyrate-producing bacteria were more depleted. And those two families in particular, that's a meaningful distinction here. It tells us that the protective effect isn't just about having a lot of bacteria. It's about having the right bacteria in the specific metabolic world. When these two families are depleted, butyrate production decreases, and the gut environment shifts in a big way. Candida gets a different set of environmental signals, and in response, it changes. If you want to go deeper into that study, I've put together a free research summary as well, with the key citations as well as my take in plain language on them. The link is in the pinned comment and the description below, so check that out. So here's where the most common treatment logic starts to break down. Antifungals are effective at reducing Candida load, whether it's a pharmaceutical like fluconazole or a botanical approach like oregano oil or caprylic acid. They can meaningfully reduce how much Candida is present in that moment, and that's why people initially feel better. The symptomatic load drops, the load on the system drops. But antifungals don't repopulate the two species that are undergrown in most cases. They don't rebuild the butyrate producing machine and capacity that is required to keep Candida suppressed in the first place. In fact, some antifungal approaches, whether botanical or prescription, can add to the dysbiosis pattern. That's the disruption of your bacterial microbiome, not because they're harmful in isolation or black and white, but because the treatment, without concurrent terrain work, leaves the gut environment in the same depleted state that invited the overgrowth to begin with. So when symptoms come back 4 to 6 weeks later after finishing a course, that's not a treatment failure necessarily. That's a terrain problem that was never addressed and looked at. This is where the clinical picture starts to look different from what most people have been told. Across 13 randomized controlled trials, probiotic use was associated with a significantly lower risk of Candida colonization in patients. And perhaps more notably, the evidence was more consistent in people who already had active Candida involvement compared to the prevention-only populations in these studies. What this means practically is that restoring specific bacterial populations alongside antifungal treatments isn't optional if you want a more predictable outcome. It isn't extra either. It's part of the strategy that changes whether or not your treatment holds. And I see this in practice regularly. Someone who comes in with a history of 4 or 5 rounds of antifungals over the past few years, and each round works to resolve symptoms for a few weeks at a time. And then when we start looking at the functional picture of the gut and their stress chemistry and even their hormones, what we find is that Candida is not the problem. It's the environment that's allowing the Candida to grow. If you want to look at the research on probiotics and Candida recurrence as well, the summary covers this alongside the other citations in this video. Again, pinned comment and description below. Before we get into what a real well-rounded approach looks like, it's worth naming what actually creates this terrain condition that allows the cycle to begin. Antibiotic use is perhaps one of the most common and direct drivers when it comes to creating that vacuum that allows Candida to grow in its place. Broad-spectrum antibiotics can't reliably distinguish between the protective or the pathogenic ones, and so the butyrate-producing bacteria can become affected, and Candida gets the opening that it needs. But antibiotics are not the only driver. Higher sugar intake or refined carbohydrate intake in some individuals creates a gut environment as well that is more supportive of fungal organisms. Blood sugar instability, particularly patterns of high insulin, changes the pH and the oxygen environment in the gut in ways that favor Candida as well. And then chronic stress chemistry and hormone pattern disruptions also affect the gut environment more indirectly through its immune signaling pathways, specifically a protein called secretory IgA, which is an immune protein that lives on the surface of your gut wall, your respiratory walls, and your digestive tract. And when it's weakened, it can allow for overgrowths to occur, Candida included. This is why two people can take the same antifungal approach and have completely different outcomes as well, because their environment may be entirely different from the others. One of them may have strong bacterial suppression capacity still intact, while the other may not, and it's driven by high stress chemistry or similar. But the most important takeaway here is context matters, terrain matters, and neither one of those things often shows up on a standard stool culture or other conventional lab test. So how do you actually address this? The sequence matters here, and that's what we're going to draw some attention to. The first step is identifying what depleted the terrain to begin with. Was it antibiotics or a diet pattern or stress physiology, blood sugar imbalance? You can't restore what's been continuously depleted. And so getting insight here is incredibly important. The upstream drivers need to absolutely be part of the conversation before anything else. The second is focusing on these butyrate-producing bacterial species in your gut. This is where things like fiber strategy or a diverse plant-based diet can go a long way in supporting these organisms. And the third is addressing Candida load in a way that doesn't further deplete the ecosystem that it's trying to restore. That's where the antifungal choice, timing, duration, context becomes clinically relevant for each and every person. Or said another way, the first question isn't what should I take, but what does my terrain actually look like right now? And that's a different kind of investigation than most people have done when approaching chronic Candida or yeast overgrowths. Here's a way to think about whether this pattern is relevant to your case or not. If you've had Candida symptoms, whether confirmed or suspected, and you've tried the antifungals, felt meaningfully better, and then relapsed within a few weeks to a few months, the terrain conversation is almost certainly a part of your picture. The treatment working temporarily is a clue that you must tune into. It's telling you that the Candida load responded, but it's also telling you that the suppressive capacity of your good microbiome didn't recover and take over. And if this sounds like the kind of pattern you've been trying to make sense of yourself, this is exactly the kind of help that I organize around my patients. And the next step is to watch the short video that orients you around the training and prepares you for a health mystery map call. If you're in one of the states that I practice in, I'd love to have a conversation with you. And if you haven't seen the companion video to this series yet, that's the place to go next. It covers the 5 symptom patterns that I see clustering together in Candida cases most frequently. The ones that people have been reading as separate problems more often than not, and at least 2 of them get commonly misread. So that video is linked right here. I'm Dr. Kenny, Root Cause Health Detective. I'll see you in the next one.